All right. Well, thanks everybody for joining us on this Monday afternoon. We're here today to talk about LVADs and complications of durable LVAD support. Today, I'm very happy to welcome Dr. Kiran Sidhu from the University of Pennsylvania, where she's an assistant professor of clinical medicine, and she's going to give us a great talk. So, Dr. Sidhu, please go ahead and take it away.
Awesome. Thank you for the intro. Good afternoon, everyone. So I'm going to talk about a topic that I think is something that we experience on a day-to-day basis. There's a lot of complications, and so I think 30 minutes is not enough to go through all of them. So we're going to focus on GI bleeding, RV failure, and aortic insufficiency for the next 30 minutes. I wasn't sure if I had to throw this in, but these are the questions for the pre-test, and we can always go through the answers at the end. So prior to getting started, sort of talking about complications, let's just review some of the basics. So this is data from Momentum 3, which is a landmark study looking at HeartMate 2 versus HeartMate 3. So the axial flow pump is the HeartMate 2. The centrifugal flow pump is HeartMate 3. Primary endpoint in this study was looking at the incidence of stroke or a need to reoperate on the pump for something like pump malfunction or pump thrombosis. And you can see that the incidence was dramatically more in the HeartMate 2, so improvement with the third generation pump. And as a result, there's less friction, heat generation, shear stress, and so downstream, that leads to a reduced incidence of hemolysis and pump thrombosis. Looking at adverse events in the Momentum 3 study, so this is the data from 2 years, you can see that incidence of pump thrombosis is dramatically reduced. So it's about 1/10 of what it used to be with the HeartMate 2. There's also a reduction in stroke, roughly 50%. But you can see that there's still a high incidence of bleeding, and GI bleeding is still occurring about 1/4 of the time. Right heart failure remains a real problem, occurring in about 1/3 of our patients, as well as infections. And I won't get into driveline infections and other infections today, but you can see that infections are a real issue. Looking at 5-year outcomes that were recently published from the Momentum data, you can see that there still is an improvement in hemocompatibility-related adverse events. So the combination of thrombosis, stroke, and bleeding, roughly 4% in the HeartMate 3 and about 2.5-fold higher in the HeartMate 2. Looking at strokes by themselves, you can see that the stroke incidence is highest in the first 2 years. And then if you get past that 2-year mark, the stroke incidence really drops off. And thrombosis, we're seeing just very low rates, around 1%, even at 5 years. So switching gears to GI bleeding in LVAD patients. So the first sort of series that looked at trying to understand the cause of GI bleeding in this population was from the Mayo Clinic. This was back in 2009, so older generation pumps. They looked at roughly 100 patients looking at GI bleeding 2 weeks post-LVAD implant. These patients all had a positive fecal occult blood, and they needed a blood transfusion for their hemoglobin drop. And what you see here is that there was a real increase in GI bleeding in patients with the continuous flow pump versus the older generation pulsatile pump. So something about continuous flow that was causing an increased incidence of GI bleeding. So what are some of the mechanisms that could be underlying this? So we know that in the setting of continuous flow pumps, there's a reduced pulse pressure, and that at the level of the tissues can lead to tissue hypoxia. There's increased sympathetic tone, and that can lead to the development of AV malformations, as well as we talked about previously. In the older generation pumps, there was more shear stress. There is still some shear stress, even with the HeartMate 3, though much less than before, and that can lead to shearing of von Willebrand multimers into fragments, and downstream this leads to an acquired von Willebrand syndrome. And then through several mediators like VEGF, this leads to an increase in angiogenesis, so development of these new blood vessels that may be a little bit more fragile, and then as well as impaired platelet aggregation. You take all of these three things in the setting of anticoagulation and sometimes super therapeutic INRs, and it's kind of just a perfect storm for bleeding. Excuse me. This was a recent model that was developed out at the University of Michigan. So if you look through the literature, there are a lot of different models to predict GI bleeding in LVAD patients. This one is specific for HeartMate 3, so I thought it was the most relevant in the current context. So they looked at patients from the STS and the Intramax databases, roughly 6,000 patients, all had HeartMate 3s, with a GI bleeding incidence of about 16%, so a little bit less than we saw in Momentum 3. Through initially univariable analysis and then multivariable modeling, they came up with 13 pre-implant risk factors that help predict post-LVAD GI bleeding. And then when they categorized patients based on their risk score and divided them into low, intermediate, and high, you can see that this model did sort of help delineate who is at highest risk for GI bleeding. And when you plug numbers into this model, it helps predict GI bleeding at 6 months, 1 year, and 2 years. And this is what the model looks like. I've sort of copied the website at the bottom, so you can take your patient's variables and plug them in. So you can see all the variables on the side here. And many of these things are things that we already know of. So things like frailty, having underlying liver dysfunction, prior ulcers, being sicker going into VAD, having RV dysfunction. All of these are risk factors for GI bleeding. And then, like I said, this risk score will tell you what their risk of bleeding is at different time intervals. And I think this really helps when you're talking to patients pre-VAD in terms of what complications they can expect and what we should be watching for as well. So now you have a patient post-LVAD and they come in with GI bleeding. Oftentimes these patients are coming in with low flow alarms. So GI bleeding should be one of the things on your differential. And then you just want to see them and assess whether they're stable or unstable. If they're unstable, they'll need to be resuscitated more quickly, have their anticoagulation reversed, and probably be in an ICU environment. If they're more stable, like most of our GI bleed patients, they come in with sort of a chronic ooze from their GI tract. They'll come in with a low hemoglobin, but usually won't be crashing. They can often just be admitted to a heart failure service where some amount of reversal needs to still occur. They need to receive blood products, and then getting GI involved for usually initially an EGD and a colonoscopy, though those are usually unrevealing. I mean, these patients still can have ulcers and diverticulitis and other causes of bleeding, but we know that the most common cause of bleeding is AV malformations. And so usually the upfront testing is negative, and then you end up doing either a video capsule or going straight to some sort of small bowel imaging like a double balloon or push enteroscopy, which will help identify usually small bowel AVMs, but can also have large bowel AVMs that GI can then either use APC or whatever techniques they want to deal with the bleeding. If no source of bleeding is found, other modalities can be used, but usually these are if bleeding is more brisk, so things like a tagged RBC scan or a CT angiogram. Once the bleeding is found and hopefully dealt with, the next steps are thinking about, well, withdrawal of antiplatelet therapy, and we'll talk about the ARES trial, as well as potentially modifying your INR goals. And then with recurrent GI bleeding, I think it makes sense to think about preventative measures such as octreotide or thalidomide, which we can talk about a little more as well. There are a few agents that have a bit of evidence. This isn't the strongest level of evidence, but there is some evidence for primary prevention of GI bleeding with drugs such as ACE inhibitors and ARBs, as well as digoxin, which are agents that we often use routinely in these patients anyways, as well as a little bit of evidence for omega-3 fatty acids. The secondary prevention is where there's a little bit more evidence. So the mainstay are drugs like octreotide and thalidomide, and you can see here even still the trials are small and many are single center studies, but octreotide works via splanchnic vasoconstriction. And so many of you have used it in the setting of variceal bleeds as well. It also inhibits angiogenesis via the VEGF pathway. And small studies have shown a decrease in rebleeding with octreotide. Octreotide needs to be delivered subcutaneously either twice a day or monthly via an IM injection. Oftentimes, this is limited by GI side effects. The second line agent is thalidomide. The reason to use it second line is it often can be prothrombotic, and so shouldn't be used in a population with a history of pump thrombosis. There's a small randomized controlled trial in this population where they found that in patients that were on thalidomide, their bleeding episodes were decreased by more than half in the first year of follow-up. Thalidomide is a tablet. It is a highly teratogenic drug, and so that is something that, women of childbearing age should not be handling it without proper precautions, as well as it can be limited by side effects such as peripheral neuropathy and fatigue. And then there's a little bit of evidence for drugs like danazol and tamoxifen that are, used much less often. And then I don't think a discussion about GI bleeding would be complete without talking about the ARES study. So this was published late last year in JAMA, looking at patients. All of these patients had HeartMate 3s. So roughly 600 patients were randomized to either, so everybody's on background warfarin, so either aspirin or placebo. You can see it's mostly male patients, roughly age of 58 years, and it's a multi-center study with a primary endpoint of looking at survival-free of those hemocompatibility-related adverse events, so things like stroke, pump thrombosis, bleeding, or any sort of peripheral thromboembolic complications at 1 year. So this is a non-inferiority study. They were looking at a 10% non-inferiority margin, and you can see that withdrawing aspirin, so the placebo arm seemed to do better and did fit their non-inferiority criteria, with a 6% reduction in that primary endpoint. And you can see that the curves separate early on that right-hand side. They looked at some secondary endpoints as well. So looking at death or any of those sort of primary endpoint adverse events. And you can see once again, survival free of those endpoints was higher in the placebo group. And there was also less non-surgical bleeding events in the placebo group. That makes a really strong case that, in most patients, I wouldn't say all patients, there's some patients that may still have a compelling indication for aspirin, but in most patients, we are now not starting aspirin after VAD implant. And, I don't think ARES really discussed what to do with patients that were already on aspirin prior to, and whether we should withdraw aspirin in those patients. And, anecdotally, we seem to be doing that as well. There was also a lot of discussion at ISHLT about various sub-studies of ARES, and one of them was looking at time and therapeutic range. And so in addition to dropping aspirin, making sure that your patient is in therapeutic range, so whatever that INR target is for that particular patient, and making sure they're in that range more than 56% of the time, so not too high or too low, seemed to have an additional reduction in bleeding events. So we'll switch gears to looking at RV failure, and I'll just take questions at the end if that's okay. So sort of taking a step back in time here. So the Intermac's definition of RV failure came up many years ago, and they've essentially stratified RV failure based on severity. So how long are you needing inotropes, and are you going to need an RVAD? Regardless of the severity of RV failure, we know that the presence of RV failure in itself is associated with higher mortality, both at 6 months and 1 year. You can see this is an older study from Dr. Kormos and colleagues, and you can see that RV failure is associated with nearly a 40% mortality at 1 year, as well as associated with significantly long hospital stays and readmissions for heart failure. And even in the current era, as I showed you from Momentum 3, roughly 1 in every 3 patients develops early RV failure. And then there's this whole phenomenon of late RV failure that we can also talk about. As mentioned, the duration of RV support can be a predictor of outcomes. So looking at those various sort of worsening risk profiles, you can see that 2 weeks is maybe a cut point after which, if you're requiring inotropes for more than 2 weeks or an RVAD, your survival probability really drops off. And then RV failure is also associated with things like heart failure hospitalizations and GI bleeding. And you can see that if you do a combined endpoint, none of these groups is really doing very well. But once again, there seems to be a little bit of a cut point of patients who needed inotropes for less than 2 weeks, but really all of these groups are doing poorly. This is a fabulous slide. I didn't make it. This was a slide that was recently in a review paper in JACC, and I think this is phenomenal. So you have somebody in front of you, they've had an LVAD put in, and now they have post LVAD RV failure, and how are you going to manage them? So it's kind of back to first principles. So things like preload, afterload, contractility. So these are slightly different in the setting of a failing RV. So maintaining that preload. So the RV likes to have a little bit more preload, maybe keeping your CVP in the 10 to 12 range, optimizing sort of their peripheral vascular resistance. So using things like inhaled nitric or Flolan in an effort to sort of recouple the RV and the PA. Using inotropes. So if they have enough blood pressure, using inodilators. If they don't have enough blood pressure, using medications such as epinephrine to ideally get their CI into a normal range. And that will therefore allow the RV to supply preload to the LVAD, allow the LVAD to work better, keeping the MAP at least 65 to perfuse the coronaries, especially the right coronary. And then some evidence that pacing these patients a little bit faster. So I'd say probably 90 is ample. There's some data out of MUSC that pacing at 110 can actually be harmful. So keeping the heart rate a little bit on the higher side and potentially even turning off the LV lead. This is more for late RV failure, but there is some association with ongoing BiV pacing and late RV failure. And then really just preoperatively having a committee meeting, deciding who we think is at risk for RV failure based on both echo as well as hemodynamics. So looking at things like PAPI, if the PAPI is close to 1, or if their CVP wedge ratio is climbing above 0.6 or is actually reaching 1, where your CVP and your wedge are essentially the same number, are suggestive of patients that have severe RV failure, and sort of taking a step back and being like, should we be VADing these patients? Do they have any other options like transplant? And if they don't, then perhaps these are patients that need to come out with upfront RV support rather than waiting for them to start crashing and developing end organ dysfunction and then going back in and putting in an RVAD at that point. That usually goes less well. Switching gears a little bit to late RV failure. So rather than patients developing RV failure immediately post-VAD, some of these patients will develop later RV failure at least 30 days out, or sometimes even a year out. So chronic VAD support can often lead to late RV failure, and you can see the incidence is much lower. So rather than 1 out of every 3, this is kind of more in the 5 to 13% range. Risk factors, I think many of them are quite intuitive. So going in with impaired renal function, having an RV that's dilated, having moderate to severe TR, all of those things really set you up for, trouble with your RV down the road. And then post-op risk factors, going into an atrial arrhythmia, losing your atrial kick, new aortic regurgitation, as well as persistent MR, can both increase left-sided filling pressures and then pulmonary pressures, leading to some increase in your RV afterload and sort of some RVPA uncoupling at times as well. And so those are things to watch for and sort of aggressively treat to try to keep your patient from having post-operative RV failure. Comparing late RV failure to early RV failure, we can see that those who develop late RV failure do even worse. And so we know that the early folks don't do well, but if you develop late RV failure, your survival is reduced even further. And then just kind of systematically going through things like pathophysiology, which I haven't really touched on. So whether it's early or late RV failure, why does RV failure happen? And so one of the reasons is that once the VAD goes in, the septum now, as the heart is decompressed, bows over to the left side. And so the RV loses that septal component to its contractility. So we really should be making an effort to keep that septum a little bit more midline. And then in addition to that, the RV is now seeing a lot more preload. You're flowing your LVAD at 4 to 5 liters, and perhaps the RV has not been used to seeing flows that are quite that high. Couple that with things like long pump runs, perhaps low blood pressures in the operating room, bleeding, requiring a lot of blood products. All of those can stress an RV that's already fragile. And then there's some debate about whether anything needs to be done at the tricuspid valve level. And, the jury is still out. There's definitely some trials that suggest that outcomes are better, and other trials have suggested really no benefit to doing a tricuspid valve intervention. It also adds some time on pump. And so it's something that I think needs to be weighed on a case-to-case basis. Signs and symptoms, I think you guys are all familiar with the signs of RV failure. Often these patients will also show up with low flow alarms just because the RV is not supplying that preload to the LV. And then, as I've mentioned a few times, RV failure does really set you up for hemocompatibility related adverse events. So not just GI bleeding, but there also is an increased incidence of pump thrombosis and stroke in these patients. Management, we sort of talked about in the other slide. I think in patients that are, outside of the hospital, other things to consider are bringing them in for a speed optimization using both echo and right heart cath to try to optimize RV performance, potentially using drugs like digoxin in those who have preserved renal function, and then really thinking about the trajectory. Are they a transplant candidate? Can we use this worsening RV failure as a way to get them a higher status? Do they need home inotropes? Those things also need to come into the discussion. There is a very cool new risk calculator that literally just came out like 2 months ago. I think this is something we also need to be doing preoperatively, both, to educate our patients as well as ourselves in terms of who's at high risk for RV failure post-op. And so this was a study led out of the University of Utah. There was patients enrolled at Inova as well as Henry Ford in the derivation cohort, and then the validation set was done at Stanford. This is continuous flow LVADs, not just HeartMate 3. Primary outcome looking at the incidence of RV failure. So this is like the more severe patients who require inotropes for more than 14 days or an RVAD. And the C statistic in this particular model is higher than any other previous risk prediction model that we've had for RV failure at 0.75. Similar to the GI bleeding model that I presented earlier, this allows us to sort of risk stratify our patients into sort of a low, moderate, and high risk profile. And you can see, this is just an example that I pulled up, but you can go in and put in some of these prognostic factors for your personal patient, and it pops out what their risk is. And then once again, just going through some of these factors. So anybody that's like on support, Intramax 1 or 2, obviously is not going to do as well. Those that have a higher CVP to wedge ratio, and then things like an elevated creatinine, inability to be on an ACE inhibitor, all sort of predict what their hemodynamics are going into the LVAD. This is a little bit of a busy slide, but this kind of reinforces some of the stuff that was seen in the early days by Dr. Kormos and colleagues. So in their derivation cohort, once again, they saw survival was dramatically reduced in those who had RV failure compared to no. And this was also seen in their validation cohort. Looking at sort of grades of RV risk, so low and moderate risk seemed to do better than those that were high risk. In the validation cohort, it seemed that the levels of risk sort of predicted survival a little bit better than in the derivation cohort. And then once again, this is somewhat intuitive, but comparing patients that were not having RV failure to those who needed just inotropes compared to those who needed an RVAD, you can see that there's a stepwise decrease in survival, and then once again seen in their validation cohort. So it seems that this model does sort of pan out pretty well, and I'm hoping to start using it more in our selection meetings, because we often talk about the RV, but it would be nice to actually have like a percentage risk that we can sort of throw into the equation going in terms of whether patients need RVADs. So all of these things, whether it be RV failure or aortic insufficiency, are sort of termed hemodynamic related adverse events. And so you can see, as we talked about, there's a subset that get early RV failure. And we know that early RV failure does set you up for late RV failure. So even if you recover, you leave the hospital, your RV is just not great. And so over time, whether that be a year, these patients often develop right heart failure, and then aortic insufficiency, which I'll talk about next, also seems to happen a little bit later, versus the more hemocompatibility related adverse events, things like strokes and bleeds, kind of, especially strokes often happen early. And then as you get farther away from VAD, you're less likely to be having a stroke. Comparing right heart failure versus in the HeartMate 3 versus the HeartMate 2, really no improvement, at least early on. Perhaps later on, HeartMate 3 is suggesting a little bit more right heart failure, and that, that's interesting. That's definitely one thing that has not improved with the newer generation VAD. Aortic insufficiency, however, has, and we'll get into this data a little bit more with the next set of slides. And then in the last 5 to 10 minutes, we'll talk about aortic insufficiency. So in terms of risk factors, multiple studies have looked at this. There's a long list of things that can lead to aortic insufficiency, but I'd say some of the ones that consistently come out in various trials are a persistently closed aortic valve. And so we should make every effort to try to have that valve open every few beats. If it's persistently closed, the valve often gets fused, or the leaflets aren't totally closed, but are fused in an abnormal manner that can lead to downstream AI. Female gender and older age seem to come out over and over. Having systemic hypertension or a high afterload state, larger aortic root dimension, or excessively unloading the LV, which is essentially a surrogate for keeping the aortic valve persistently closed. In terms of pathophysiology, you can see on the schematic on the right-hand side here, looking at a patient with an LVAD. So say number 2 is your left ventricle. The VAD is pulling blood out of the heart through the motor into the outflow graft and then returning it to the aorta, which is the number 1 here, and then off to the rest of your body. In the setting of aortic regurgitation, you can see that you develop sort of this blind loop. So blood comes out of the outflow tract. Some of it is going to the body, and then a chunk of it, 30 to 50%, depending on how bad the AI is just stuck in this kind of recirculation loop. And so these patients often will have preserved flows or even slightly higher flows, but their effective forward flow is reduced, and as a result, often come in with things like fatigue and shortness of breath. Our classic echo parameters that we use for non-VAD patients are not as great in terms of assessing AI in the VAD patient, just given that it's more of a continuous AI situation. So I think some things that we should still look at, regardless of if it's a VAD or not, is the LV dilated? What does the aortic valve look like? Is it opening? Is there root dilation? And then things that are specific to a VAD patient, and this is sort of like a more novel scoring system that's been developed by the group out of the University of Chicago. It's not terribly novel. It's been out for about 8 years now. I just don't think it's being used as much as it should. And so what they're doing here is it's a parasternal long axis. They're looking at the outflow graft and just doing a pulse wave Doppler at the level of the outflow graft. And so you can see they're putting a mark here. This is your peak systolic flow, and the D is your end diastolic velocity. And so you're doing a ratio of S to D, and as that ratio starts to drop off, so with worsening AI, you have more diastolic flow. So then the S to D ratio decreases, and when it decreases less than 5, that's an indication of more severe AI. You also get more diastolic acceleration. So the diastolic acceleration is looking at this slope here, and more than 49 is associated with severe AI. And so when they tested these newer echo parameters compared to older ones, such as vena contracta, these newer measurements fared better with respect to properly grading the severity of the AI, and seemed to jive more with regurgitant fraction, with wedge, and also seemed to predict who the patients were that were going to need heart failure hospitalizations or interventions. So using conventional parameters seems to underestimate AI. So what are some consequences of AI in LVAD patients? We know that AI worsens over time. And so once again, we need to be making a preoperative assessment of the aortic valve and see if anything needs to be done in terms of valve repair or oversewing the valve or whatever it may be to deal with AI at the time of VAD. So you can see at baseline, many of these patients did not have AI or just had mild AI. And as time goes on, the amount of patients with no AI starts decreasing. More patients have mild, and likely the patients that had mild AI are now progressing to moderate to severe. There's also been studies that have shown that significant AI at baseline increases the incidence of death or readmissions for heart failure. And you can see there's like nearly a threefold increase. So AI at baseline should not be ignored. The Momentum-3 study recently looked at de novo AI. So these are patients that had no AI going in and developed AI while they were under LVAD support. And so you can see here that over time, similar to the last slide, you're seeing more and more AI. Luckily, this is something that is improved with the current generation VAD. So HeartMate 3 is consistently less AI than its HeartMate 2 counterpart. And you can see there's roughly a 50% reduction, but we're still seeing an incidence of 5 to 6% of patients having AI, and we can see that they don't do well. Interestingly, though, in Momentum-3, when they looked at de novo AI, they found that this did not impact survival free of needing an urgent transplant or some sort of procedure, but they didn't look at heart failure hospitalizations or mortality. So I think their endpoint's a little bit different. And then once again, the risk factors that they identified in their particular cohort was female sex and older age were risk predictors for de novo AI. And so how do you manage these patients? So all of our patients should be getting routine echoes. This really depends on what center you're at, but every 6 to 12 months. If they do develop some amount of AI, then we need to be thinking about, do we need to do a VAD optimization? Can we perhaps lower the speed to allow the patient to have less AI, prioritize some aortic valve opening, and then obviously working on afterload reduction and diuresis, using the more novel grading parameters, using the S/D ratio and the diastolic acceleration time. And just as a reminder, if it's the S/D ratio of less than 5 or the acceleration time of greater than 49, suggesting more severe AI. Once again, trying to do the things we did for the more milder AI, but in these patients, do they need an aortic valve intervention? And depending on who the patient is, if it's a DT VAD, they may be too sick to undergo an aortic valve intervention, or it may be somebody who's a bridge to transplant who you may be able to use the worsening AI as a way to get them a higher status and get them to transplant sooner. Just the last 2 slides looking at the TAVR experience, initially with HeartMate 2. There's not a ton of published experience, and it's a little bit discrepant, but overall, I would say the TAVR experience has not been overall favorable. So the Houston group looked at 3 patients. They found that they were able to implant the valve successfully. So this was a sapien valve and had no complications. This really has not been replicated by other centers. So the Atlanta group looked at 9 patients. They used different valves. They also found that at least procedurally, the AI got better, but there was several patients who had valve migration that needed a second valve, and this occurs because of lack of calcium for the valve to anchor on and a lot of vascular complications. And then the Chicago group looked at all VADs, not just HeartMate 2. They used a variety of different TAVR valves. They also found that they had a reduction in regurgitant fraction, but the survival at 9 months was not great. So 30% of patients have died in this time span, and they're also noticing trouble with valve fixation. So a subset of their patients had severe paravalvular leak, as well as vascular issues. So I think certain selected patients, perhaps TAVR could work, but in the absence of significant aortic calcification, I think it may be tricky to do TAVR, and potentially focusing on just doing a bio-AVR is the way to go, depending on the patient in front of you. So in conclusion, a few of the points that we've touched on. So based on trial data from ARES, we have noticed a reduction in GI bleeding with omitting the aspirin and keeping the time in therapeutic range greater than 56% in LVAD patients. In RV failure post-VAD, sort of going back to basics, you want to optimize preload, afterload, contractility. Think about the patients who are at high risk for RV failure and have a plan to use early temporary MCS before their end organs start falling apart, and then they are kind of in this death spiral that it's hard to rescue from. We know that aortic insufficiency will get worse over time. We need to watch for it with our routine echoes. And then also incorporating the novel echo parameters. So looking at that systolic to end diastolic velocity ratio and the diastolic acceleration time at the level of the outflow graft. This is a better metric to gauge severity of AI in VAD patients. And then lastly, using the GI bleed and the RV failure risk score to help inform decision-making in our patients pre-LVAD. And that's all I got. And I can go through the answers if you guys want.
Go ahead.
Or do you want me to go through the answers? So in terms of which of the following is the cause of GI bleeding? So as we discussed, all of the above in this case. We know that late RV failure portends a poorer prognosis than early RV failure, so that's true. And then lastly, we've talked over a few slides about the echo parameters associated with severe AI, so the S to D ratio. So as you have more diastolic flow, the S to D ratio drops off and you have an increase in your diastolic acceleration velocity. So the answers here are B and D. And then I'm happy to take any questions.
Thank you so much. Before I ask a question, is there any questions from the group? You're welcome to put them in the chat or just unmute yourself. I'll wait for a moment. The question I was going to have was what on the use of like invasive ramp studies in order to optimize hemodynamics to kind of be sure that you've got your pump speed at a correct pump speed to kind of reduce your risk of RV failure. And is that something you advocate for sequentially or, as part of regular follow-up?
Yeah, so at Penn, we're doing it in all of our patients at the 3-month mark. And so prior to them being discharged, we'll just do an echo and see if any speed optimization needs to be done just based on echo. And then at the 3-month mark or around the 3-month mark, we'll make sure that we bring them in for both a right heart cath and a simultaneous echo and make any speed adjustments, mostly to see if we can decompress the LV. Many of these patients still have very dilated LVs when they leave the hospital, but also in the setting of AI or RV dysfunction, trying to optimize the speed to sort of lessen those issues as well.
Fantastic. And the other question I had is just kind of, in my experience, I haven't used the thalidomide.
Yeah.
You start making that consideration about maybe moving beyond octreotide to consider thalidomide in patients with GI bleeds?
Yeah, so as I was telling you before, I trained in Canada, and so or I've been working back in Canada before coming to Penn, and so in Canada you need to write to the government to get thalidomide, so it was like quite the process. But in terms of like thought process for who needs it, I think going through somebody has a first GI bleed, maybe just getting rid of the aspirin, lowering the INR target a little bit, and then second GI bleed, starting octreotide, and then recurrent GI bleeds. I think that's somebody that you want to think about thalidomide, but also just think of like who the patient is in front of you. Are they somebody that's at high risk for stroke or pump thrombosis? In which case I would probably avoid it. But yeah, the data and like anecdotally, the benefit of thalidomide seems to be higher than octreotide. It seems to really take care of the GI bleeding, but does have those side effects that often limit its use. And I think that's part of the reason we don't use it more upfront.
Then one question in the chat is asking a way to objectively evaluate the risk of thrombosis in a patient when you hold anticoagulation after a bleeding episode.
An objective way to tell if they're going to thrombose. So for the most part, and this is once again anecdotally, we often get away with holding anticoagulation in HeartMate 3 patients. So we're not routinely anticoagulating patients. So say somebody comes in for like a colonoscopy, we might just hold their warfarin and not bridge them. And usually you get away with that. So the HeartMate 3 pump is like a very forgiving pump. It's not very thrombogenic. I think there are patients that are sort of prone to clotting for other reasons. So say they have AFib or, they've had a stroke in the past or, something else that would make you worried that they're potentially prothrombotic. I think those are the ones to worry about. But in the absence of that, I feel like we often get away with lowering INR targets or just holding warfarin entirely in a subset of patients. But that's not based on trials. That's based on just what I've seen done.
Okay, and then we got a couple more questions that just came in.
Yeah, okay.
If a patient is not on anticoagulation,
Yep.
to try to optimize their pump speed.
If they're not on anticoagulation,
Yeah.
That's a little dicey. I mean, if their INR's like 1.8 and I'm just turning their speed up or down a little bit, I'd be okay doing that. But yeah, I tend to not want to do huge speed changes unless they're properly anticoagulated.
And then the other question is, and I'm not sure if this would ever be the case, but like
Yeah,
somebody did not have an ICD, but
yeah.
would you ever consider a primary prevention ICD?
Oh, that's so funny. This is like an area of a lot of interest for me. So like what to do with devices post VAD. There is no survival benefit to our primary prevention ICD post LVAD. If somebody's had VT post VAD, I think there's some benefit to a secondary prevention device, but many of these patients will walk in with VT or even VF, and you can sort of see them in the ED, sedate them, cardiovert them, and then put a device in. But I think if somebody has made it to a VAD without an ICD, I would not put in an ICD just empirically. There's also a risk score called the VT LVAD score that helps sort of figure out who's at high risk for developing VT post-VAD, and then you can kind of throw that into your risk calculation in terms of like who really needs a device versus not. But, you know, most patients post-VAD do not need a primary prevention ICD.
All right. Well, thank you for answering all of our questions and delivering
Yeah,
some
of course.
very interesting. And thanks for everybody for taking the time to join. We will be back on Friday with the use of stress and exercise testing in heart failure. So see you all on Friday.
Cool. Thanks for having me. Take care.